prolific writer, researcher, teacher, scientist, one of the few doctors, surgeons who are PhD also. So basically, so he does epidemiological research as well as clinical research. And he travels widely. He's worked in famous Royal Marsden Cancer Hospital in Britain, in London, and worked with some world-renowned breast experts like Professor Michael Monk. You read a lot about Dr. Michael Monk in recent months. Some of the Indian doctors also famous in the field of breast surgery, like Dr. Ismail Jatoi. He also worked. So Ismail Jatoi worked there.
No, Mitra was before me, I think.
Okay.
But I know Mitra quite well.
Yeah.
I know Mitra.
That was the feeling I had, that we had long association. And I know Rajan Bhatt as well.
Right.
And his mother worked as a pathology professor in Tata Memorial Hospital. So that's his link with Tata Memorial. And he has been a regular visitor in Tata Memorial for a long time. And this is where I met him first, about 10 years ago, because every year they have this women cancer initiative meetings and they invite experts from all over the world. So I met Professor about 10 years ago. And since then, I've been associated and learning a lot with his methods. And he has been very kind enough to visit NIMS almost on a regular basis for us. Sir, please come forward. And we used to conduct the NIMS breast course together. And this is a professor of medical oncology, Professor Balvir, Professor Ismail Jatoi from San Antonio, Texas. Professor Balvir has recently joined our institute as chairman of the Department of Oncology. And he was working in the famous postgraduate institute in Kashmir, in Srinagar, the capital of Kashmir. So with that brief introduction, he had a long flight, from Texas, San Antonio. So Texas to Dallas, Dallas to Doha, Doha to Delhi, then Delhi. So he is a bit tired and jet lagged, so we'll not disturb him. I thought it will be just informal saying hello to him and greeting him. And then from tomorrow we will start set of academic activities, interactions. And as they say, maximize the benefit. So we'll maximize the benefit of his visit here and learn as much as possible. We are trying to set up breast services here. That's the reason why I was hired to this institute. So they have a clinic in the city of Jaipur, which is about 40 kilometers from here, and plus clinic here, Breast and Endocrine.
So should I just take questions?
Please.
Okay, so I just arrived like maybe a few hours ago, so a little tired, but I'm happy to take questions. If anybody's got questions about anything, doesn't matter.
You can ask any question related to breast surgery or how you should get trained to be such a world-renowned person if he reached almost the pinnacle, the top of his field in breast care. So you can ask how to climb the ladder of success in surgery. You can ask how to get trained in America.
Thank you.
Abdali sir, would like to know how he succeeded in his life. Yuvraj.
Yes, sir. What is the present status of neoadjuvant chemotherapy and neoadjuvant therapies in the breast seed?
So
there is no surgical intervention.
Yeah, so neoadjuvant, I think, is being used more and more often. But I think sometimes it's also inappropriately used. So it'd be interesting to see what everybody thinks. But I would say that we use neoadjuvant in case of inflammatory breast cancer. Okay. We also use it for locally advanced breast cancer. Locally advanced meaning, so how do we define locally advanced? I don't know. These are medical students, residents?
Or postgraduates.
Okay, but
surgery residents. Yes.
How do we define locally advanced breast cancer?
Define locally advanced breast cancer.
Involve the skin.
Yes, so it's a lesion that's ulcerated through the skin. Okay, so we give neoadjuvant for those patients. So we give for inflammatory. What's inflammatory? What's inflammatory breast cancer? Well, inflammatory breast cancer is a red breast. It mimics mastitis. So patients who have inflammatory breast cancer get neoadjuvant chemotherapy. They then get total mastectomy. They don't get breast conservation. They get actually lymph node resection, and then they get post-mastectomy radiotherapy, and so they get neoadjuvant chemotherapy. Locally advanced breast cancers, we give neoadjuvant chemotherapy. They can get breast conserving surgery, depending on the response. Who else gets neoadjuvant? So inflammatory, locally advanced, who else gets neoadjuvant?
What about people who have aggressive biology, like triple negative?
Yeah, so triple negatives get
young
neoadjuvant.
ages below 50.
Well, I wouldn't say young age, but triple negatives get neoadjuvant. And why do triple negatives get neoadjuvant? Why do we give neoadjuvant to triple negative breast cancers? We give it to triple negative breast cancers because if after neoadjuvant there's residual disease, then they're eligible for a follow-on drug, capecitabine. That's based on the CREATE-X trial out of Japan. So triple negatives get neoadjuvant. Who else gets neoadjuvant? HER2 positives get neoadjuvant. Again, if you give neoadjuvant chemotherapy for HER2 positives, if there's residual disease, they're eligible for a follow-on drug, TDM1. So they get neoadjuvant. So inflammatory, locally advanced, triple negative, HER2 positives. Now anybody can get neoadjuvant. Okay, I mean these are the ones I would say we should strongly consider, should generally give neoadjuvant to, but anybody can get neoadjuvant. And I think to some extent it's being overused. Some patients will opt for neoadjuvant that have a large tumor and a small breast, and they're interested in breast conserving surgery. So some patients with a large tumor, small breast, who are interested in breast conserving surgery will get neoadjuvant to make the tumor amenable to breast conservation. The tumor will be shrunk down with the neoadjuvant, and so they can then get lumpectomy rather than the mastectomy, which they don't perhaps want. So you can give it for large tumors, patients with large tumor, small breast, who are keen on having breast conserving surgery. Okay, so again, inflammatory breast cancers, give neoadjuvant, and we follow that with mastectomy. We follow that with axial lymph node dissection, post-mastectomy radiotherapy. Locally advanced breast cancers, as you point out, get neoadjuvant chemotherapy. Triple negatives get neoadjuvant chemotherapy, so they're eligible for the follow-on drug TDM1. HER2 positives get neoadjuvant chemotherapy because they're eligible for the follow-on drug. The triple negatives get because they're eligible for the follow-on drug capecitabine. The HER2 positives get it because they're eligible for the follow-on drug TDM1 if they have residual disease after neoadjuvant. And then, of course, patients with large tumor, small breasts who want to have breast conservation can get neoadjuvant chemotherapy to shrink the tumor down and make it amenable to lumpectomy. But anybody can get it, and I think to a large extent it's being overused. There are people getting it, women getting it who perhaps should not be getting it. And so what ends up happening is if you overuse it, then you're giving patients perhaps chemotherapy who otherwise may not have gotten chemotherapy, right? So that's the problem.
Now, we've been hearing about this studies in basic tumor biology, right, from the work of Bernard Fisher, that it's systemic disease right from beginning, almost being known. So that was the basis of starting initial systemic therapy.
Right.
So if tumor is more than 1 centimeter in size, lady has to get chemotherapy after surgery. So if that is the case, why not start a priori before putting the knife? Because then we will get an opportunity to tailor the response to therapy. In case it doesn't regress completely, then after surgery, after 2 or 3 cycles, if tumor is not regressing or progressing, we stop, cut out, and then offer second line chemotherapy because we know the first line did not work.
Right. So I think that's intuitively very appealing. Unfortunately, randomized trials have shown that giving chemotherapy before or after surgery makes no difference in terms of overall mortality. You know, the B18 trial. And there's also been that trial, I forget what is it, was it the B27? Where they did the switch. And if the hypothesis that you laid out, Anurag, were in fact the case, you'd have expected to see a benefit with the switch, but you didn't see a benefit with the switch. So that hasn't been borne out. I think one of the things to keep in mind about medicine is it's counterintuitive. Breast cancer is counterintuitive. You know, I mean, I had the same thoughts that you had, and then it ends up being not to be the case. So I don't think we can plan treatment plans, algorithms based on an intuitive understanding of the disease. There has to be randomized trials. There has to be good evidence. Okay, so that's how we should plan. Now sometimes, you know, the trials are underpowered. You don't see an effect, and so you wait for the meta-analysis. You know, you combine multiple trials, then finally the effect is teased out in the meta-analysis, even though it may not have been seen in the individual trials. We see that oftentimes. But at the end of the day, we need to wait for good evidence. We can't use our intuitive understanding of the disease to base treatment strategies. You know, it's counterintuitive. Breast cancer is counterintuitive. You know, I mean, I don't think screening works. You know, you would have thought earlier detection the better. The health insurance plan trial in New York, and we'll talk about screening tomorrow, but some of the trials showed benefit. More recent trials have shown no benefit. So I don't know if the screening really works. You know, I would argue probably does. One breast cancer
will translate into one death at 15 years.
Right.
So it's a more long-term thing.
Right. So 4 local recurrences lead to 1 extra breast cancer death over a 15-year period. That was the 2005 analysis. So local recurrences do seem to matter.
Recurrences in heart failure or death. Then, and all the previous trials showed that breast conservation had more local recurrences compared to of B06, lumpectomy versus mastectomy, quad trial of Vervezi, quadrectomy versus mastectomy, did not show a difference in survival even at the end of 20 years.
Benefit, okay? So let me phrase it differently, okay? Is no evidence of benefit the same as evidence of no benefit? Yes or no? No benefit. You want to answer? You're raising your hand. What's the difference between the two? So you can have no. So I think what Professor Srivastava is getting at is that the individual trials should. That's not the truth. There's no evidence of benefit. It's not that there's evidence of no benefit. There's no evidence of benefit. And there's no evidence of benefit because you don't have adequate sample size to tease out the effect. So we say evidence of no benefit, you probably need a non-inferiority trial. And we can discuss that perhaps. But I think that's something to keep in mind.